Morning, folks. This is my first day off after a 4-day stretch. Kind of in that work hangover mode, but I'm having some coffee, so I figured why not go live. Luke, I see you, brother. My schedule is I work 3 14-hour shifts in a row, Monday, Tuesday, Wednesday, and then I get 4 days off in a row. I try to pick up at least maybe every other week and grab a shift just for a little bit of extra money. I have a California trip in April, and so I'm trying to bank a little bit of mad money for that trip as well. So I did a 4th shift, but that's hard on me, man, because those 3 14s, even though I love my 4 days off in a row, 3 14s in a row is very exhausting. So having an additional 12-hour shift, that's a little bit hard on me. So today is a 0 day for me. Nothing is going to happen today. Do you work in an ER or an ambulance? I work on the ambulance. It's all I want to do is work on an ambulance. I've never had a job where I had to work in like a single building all day, like an emergency room, office, or whatever, and I'm just not wired for that. Good morning to you as well. IV has been a big discussion over the last 24 hours. It's hard to have discussions about AVs because it's one of the things that, EMTs and medics can do that we really like to do. And so, it can make emotions run high when there's any criticism there at all. Pulling a 12 in the ER today myself after a week of 12s. Well, hang in there, man or woman. Do you use droperidol for agitated delirium? 4 milligrams IM. We do not have droperidol. Good morning, Iceman. We have Versed and ketamine, and I prefer to use ketamine. I love ketamine. Are you superstitious with full moons and Friday the 13th? I am not. I rarely give it any consideration at all. My superstition, my biggest EMS superstition, is when we start getting within a few hours of end of shift, anybody starting to talk about end of shift. Do not talk about it. Do not perform any action that means that you anticipate it. Nothing. I want to pretend like end of shift doesn't exist and then be pleasantly surprised when we get off on time. I had a partner who, admittedly, I did not like them very much, but we were fueling, but we had not been given permission to go down yet, and she started loading our stretcher with all of our stuff, and I thought I was going to have a heart attack, and we ended up getting a late call, and I, to this day, still blame her for that. Lidocaine or amiodarone, doesn't matter. There's not a body of evidence for either one for increased survival. There may be a little bit of evidence for amiodarone early in the code. When you first get that VTAC or VFib, but there's not a body of evidence. Excuse me. So there's a couple of studies that maybe show increased survival with lidocaine or amiodarone. Maybe slightly increased survival with amiodarone, nothing outside of the margin of error though. But there's also studies that show absolutely no difference between a placebo and lidocaine and amiodarone. And when you want to make changes here, you're looking for a body of evidence. It's like with bicarb. There's a body of evidence, meaning there's multiple studies that show that survival is decreased with empiric administration of bicarb. But there's not a body of evidence with amiodarone and lidocaine, so it really doesn't matter. I get worried when we're sitting too long because I know we're going to pay for it. Yeah, that's usually the case. We certainly don't sit for very long where I am. Every once in a while, we'll get that hour-long post, and I'm just grateful for every minute of it, but it's not very often. There was a time, but not anymore. I start EMT class next week. I hope you have your book now, and I hope you're reading now, because the best thing that you can do for yourself is stay ahead of your reading. Not stay current, stay ahead. Read several chapters ahead of where you are in class, and then get another read of the current chapter right before class. And you will thank me for that. And memorize all the medications that you're supposed to memorize now. Not in class, now, because the cognitive offload is a huge benefit. Follow those 2 steps, and you will thank me. What do you think about pre-hospital ECMO, like they've been doing in Paris? You talk about bringing ECMO to the patient. Look, ECMO is a game changer when it comes to cardiac arrest. But, everything has a cost. We thought that bringing Reboa, which is a way of occluding the aorta so that we're just keeping blood right at the core during, specific types of trauma. We thought that bringing Reboa to a patient in traumatic arrest or that experienced significant trauma would be a game changer. But it wasn't, at least in the couple of trials that happened. And so from a cost-benefit analysis, I'm not sure how that is going to look yet for the U.S. So I really don't have any opinion on that yet. It would be great if in specific instances we could have a team at a hospital or wherever that's ready to be deployed to perform ECMO in the field. But from a cost-benefit analysis, I haven't seen a lot of data there yet. Got to decompress a chest last night, mid-axillary. That's great, ma'am. Did you actually help that patient? Well, now, when I say that, I share your enthusiasm for getting to do something that we don't get to do very often. But was this something that benefited your patient? Did you see the result of your intervention? Pharmacology and physiology was the most time-consuming in my school. Yes, absolutely. Pharmacology is, like, to paraphrase Frank Herbert in Dune, pharmacology is the mind killer when it comes to particularly paramedic classes and anything above paramedic classes, RN, all that sort of stuff. There is a huge amount of rote memorization there that if you don't perform it, that lack, or if you don't do the memorization, that lack of memorization becomes speed bumps to the process. It's like, when you have a critical call in a neighborhood that has a lot of speed bumps, and not only just speed bumps, but the really steep, harsh speed bumps, how that slows you down to getting to that patient, and you're just so frustrated because you just can't get through. That's what lack of memorizing your medications is. They are speed bumps. Obnoxious speed bumps to your thought process. So getting ahead of that and trying to memorize that as quickly as possible is one of the biggest gifts you can do for yourself in any sort of medical certification class. Have you ever had to have an RN ride with you? We transport a patient from ER to another and the ER went. I have on multiple occasions. We have RNs that ride with us when they're getting their trauma certifications, but that's just so they can observe. But I can remember early in my career doing specific types of interfacility transports with balloon pumps and things like that, and having an RN ride with us. And at that time I didn't have any critical care training, so I appreciated having them ride with us. But at this point, I'm a critical care paramedic, and it's not very often that an RN is going. I don't ever have an RN ride with me, but an RN that's riding with me is rarely going to be more capable than I am at managing any sort of call. So, being critical care certified, they're never going to send an RN with me. So, ECMO has very strict guidelines. No, it used to be kind of like, we'll take all comers, asystole, it doesn't matter. But what they found was that was actually depleting the resources, because now people were transporting cardiac arrests empirically, meaning everyone was going to ECMO, and that not only overwhelmed the resources, but it resulted in decreased survival because you still need to give that patient a chance by working them on scene to see if you can restore some of that activity. So most guidelines have refined ECMO to be for refractory VF or VT. And the definition of refractory VF and VT is in a 10-minute period. Now, this is the general definition. Some hospitals, will play fast and loose with that. But within a 10-minute period, you performed all of your specific interventions that should be performed. So in that 10-minute period, 3 defibrillations, 2 to 3 rounds of epi, that sort of thing. EMS is trifling with super basic pre-hospital medicine. Pre-hospital ECMO? Okay, well, we don't need that line of thinking in EMS. We have plenty of advanced pre-hospital care that can be implemented, and we need to be thinking about what we can do to improve patient outcomes. And pre-hospital ECMO is a thing that you're probably going to see. And what will happen is that there's going to be a specific team that you call and say, look, we've had 2 defibrillations and this patient hasn't responded. And so ECMO is going to come to you. Or, you'll call and say that the first reported rhythm, the first observed rhythm was VFib or VTAC. And so they're going to get on their way to you just in case it becomes refractory. And that's just going to become a thing. I really don't understand that attitude. I really don't. Medicine constantly evolves and improves. Pre-hospital medicine is constantly going to evolve and improve. And I think you're going to see an overall refinement of pre-hospital medicine to have broader deployment of BLS and very targeted deployment of ALS. And a lot of that ALS is going to be very advanced compared to what we have now. Not only because it'll improve survival, but because it'll improve the way we use our resources. How do you feel about EJs? I had a nurse recently that couldn't believe I did one on a patient. Yeah, I mean, I do them from time to time, and there really, really needs to be a benefit that I can see to getting that EJ. But you're right that when we get to the hospital, a lot of nurses are like, I didn't know that EMS could get EJs, because even the nurses can't get EJs in the hospital. I mean, you go to any sort of like level 2 and above trauma center, they're all going to know that EMS can do EJs. But some local community hospital, I mean, they're just like, they just had no clue. Okay, so yeah, I'm catching up on questions here. So the person who said they performed the needle decompression said the patient said it's much easier to breathe, pressure increase O2 saturation. Excellent, excellent. See, that's a success story right there. What do you think about adding whole blood to the ambulance? I think that all ambulances should carry whole blood. I said what I said. It doesn't matter how close you are to the hospital. If a patient needs blood, then bleeders get blood. It's one of those things where if you're 5 minutes from the hospital or 15 minutes from the hospital, you're still going to save a life by getting blood to them as quickly as possible. And if you can't, if you're not anywhere close to carrying blood, at least start carrying tranexamic acid. I was listening to ICU doc talk about ECMO and that the most important is having a plan of recovery off ECMO. That's usually, I'm so sorry. That is true. There has to be a plan for what they're going to do to get that patient off ECMO. But that is more true for someone that is put on ECMO in the hospital. So let's say someone has COVID and they go to ICU and they continue to deteriorate. They've been prone positioned, they've been on the ventilator, they've been given, a host of medications, and they continue to deteriorate. They go into heart failure, respiratory failure, and so they're put on ECMO. The question has to be answered, how are we going to get that patient off of ECMO? But for like refractory VF or VT, there's no plan there. You're just trying to take over in order to perform some life-saving interventions like retrieving a clot or something like that, or placing a stent or what have you. So that's more true for a deteriorating ICU patient than it is for emergent ECMO of someone in the field experiencing cardiac arrest or coming into the emergency room with refractory VF-VT. In New York, we had to have an RN ride with us if blood was running. In Connecticut, we didn't. Yeah, I mean, I don't have to have an RN riding with me. And I don't think any of our medics necessarily have to have an RN riding with us as long as the blood was, if blood was started in a facility like an emergency room or whatever. But, things change and we have to change with the times. And, pre-hospital whole blood is a game changer. And the notion that you need an RN is becoming very outdated practice. Never, because patients need to be typed and cross-matched. O negative says hi. Even O positive. Patients are often quite given O positive without being typed and cross-matched in an emergency situation because that Rh factor isn't as much of an issue as it is with those other antigens. So the whole cross-matched thing, no, not in an emergency situation. What do you mean by the rhythm must become refractory for meeting ECMO guidelines? Most hospital ECMO guidelines, ED ECMO guidelines, require that, and I did just explain this, but maybe you jumped on afterwards, but refractory means, generally speaking, in the medical field, that something has not responded to treatment. So if someone's in ventricular fibrillation or ventricular tachycardia, there are certain interventions we perform to try to convert them out of that. So we perform compressions, we perform mechanical ventilations, we defibrillate, we administer epinephrine, we administer antiarrhythmics like amiodarone and lidocaine. And if within a 10-minute period we have performed all those interventions at the time that they're supposed to be performed, and we don't convert them out of VFib or VTAC, they're considered now to be in refractory VFib or VTAC, meaning they have not responded to interventions that should, under normal circumstances, correct that. Sounds more like the system in the UK, strict tiered system. I mean, we have a paramedic shortage in the US, and we have to do something, to be able to respond to the demand on our resources that, are there, and that's only going to get worse under current conditions. And so a tiered system with strategic deployment with medics is the only way we can go in the absence of healthcare reform. Only decompress when the BP tanks. No. You decompress when the patient, you see subcutaneous emphysema, you need to decompress. You have patients struggling to breathe, you decompress. Your oxygen saturation gets low, you decompress. I'm not sure where you're getting that, but that's that in and of itself is not evidence-based. There's a ton of logistical problems with carrying whole blood on the AMBO. We can't even move to lactated ringers. I agree. Not every service is set up to go to whole blood. But at the very least, there should be a movement by EMS in general to get to a place where whole blood is readily available. Sometimes it involves getting the blood to you. You're responding to a cardiac arrest, and so a jump vehicle, brings a cooler with blood to the scene, something like that. What's up, Greg? How you doing, man? They changed blood and antibiotics to critical care trucks here, kind of lame. Well, yeah, with the antibiotics in the U.S., antibiotics generally don't move the dial with sepsis as far as pre-hospital administration. Blood is a game changer. and gatekeeping it to critical care certainly doesn't help patients. Back to lactated ringers. For years, we carried both lactated ringers and normal saline, as we should. Isn't there a contraindication for pregnant females getting O negative? I've never heard that. Generally speaking, the streams don't cross when they're pregnant, but I have not heard that, which shouldn't be taken as a statement that, well, if EMS Avenger hasn't heard of it, it's not a thing. Simply, that information hasn't just never been in front of my eyes before. But somebody is saying, yes, that's a thing. So many studies show better patient outcomes with lactated ringers, but normal saline is cheaper. That's true. Survival in specific pathologies. Let's talk about 3 pathologies where we're really concerned about lactated ringers and normal saline, and that would be trauma, sepsis, and DKA. We all were waiting with bated breath for a study that came out about a year ago, maybe a little bit more, where we were certain that our belief that lactated ringers would improve survival and trauma, or be associated with improved outcomes, less morbidity, less mortality, that sort of thing. And we were certain that that was going to be the case, and it showed no difference. We were all like, oh, okay. That doesn't mean that you still, from a pathophysiological standpoint, don't want to do the best to your patient, but we didn't see the data that demonstrated that. In sepsis, mortality is higher with mortality is lower with lactated ringers in overall mortality. But when you start breaking it down into different groups, it starts falling apart, and you don't see that decreased mortality. God, got to get it straight here with increase and decreased. But there are definitely higher incidences of hyperchloremic metabolic acidosis. And just because your patient didn't die doesn't mean you didn't create complications in the management of that patient. So they should be getting lactated ringers. In DKA, it's just intuitive. Like, you don't need a study. An expert opinion says that somebody who's in metabolic acidosis, which DKA patients are, should not get a fluid that is not balanced, that has a pH that is acidotic, that has that strong ion difference. You should not be giving them that fluid, especially not dumping it into them. It's just not logistically or financially feasible to carry a blood bank on an ambulance, except that they do. I was told that ER docs will throw fits if you decompress, though. I haven't found that to be the case, and we don't treat patients based on what ER doctors think. We treat patients based on what the evidence says and what our own medical directors and training officers say. And ER doctors can get bent when a patient comes in with something that they don't like. And I say that as someone that definitely is a respecter of physicians and tries to develop strong relationships with ER doctors. But that line of thinking just doesn't work. Hey, Greg, it's good to see you, man. I'm sorry we didn't really get to chat this time. Thanks for stopping by. I mean, all these people are saying it's not financially possible, not feasible to put blood on an ambulance, yet it's a trend that's happening now of ambulances getting whole blood. That doesn't mean that every ambulance can carry whole blood, but to say it's not possible, the evidence just is there that contradicts you. It's possible, and it's happening. Thoughts on plasma light? I don't really have any thoughts because I don't have any experience with it. I really don't like talking to things that I just don't have a lot of experience with and hands-on experience with. I don't want to portray myself as someone who is a master of all medical knowledge. So it's not really in my lane. So sorry there. Opinions on TXA for suspected internal hemorrhage. it's a fantastic medication for that, especially for low pressure bleeds like GI bleeds. When you start getting into high pressure bleeds like intracerebral, then the data starts to be pretty uncompelling. But people should be carrying TXA, especially if you can't carry blood products. Emergency doc here, O positive blood only, relatively contraindicated in pregnant patients. Thank you, sir. Appreciate that. Thoughts on mechanical CPR devices? So I realize that messages are piling up here, and I'm going to try to get to all of these. And I'll stick around as long as possible to try to answer them. But as far as mechanical CPR, so let's say that the question is thoughts on screwdrivers when framing a house. Most of the time when you're framing a house, what you need is a hammer or at least a nail gun or something like that. And so saying, well, how about a screwdriver here? If you have a specific need to use that screwdriver, yes, you use a screwdriver. But you know what? That's a terrible analogy. That's a terrible, terrible analogy. Let me go back. Just from a tool perspective, mechanical CPR is a tool, and you want that tool to perform a specific function. And you want to be able to use that tool appropriately. And so mechanical CPR is a tool that we want to perform a specific function, which is something that we do that we don't want to keep doing for as long as we have to do it because it exhausts us and it ties up resources, and that's compressions. And mechanical CPR can do it without tiring. But if you don't use that tool appropriately, then it doesn't actually get the job done. And most of the time where it's used inappropriately is we use it as a panacea for cardiac arrest, meaning because we think that because we have this device in place, that it's just going to make everything better, and that's not the case. Mechanical CPR is not associated with improved survival rates. It is effectively a zero-sum game. It doesn't improve survival, it doesn't lower survival, it just does something for us. But if you don't know how to use it appropriately, it's actually going to lower survival. And so if you've not been trained to place mechanical CPR quickly and efficiently, you're going to disrupt that patient's compression fraction, which is the amount of time in a 2-minute cycle that you're performing quality compressions. And the more you increase the compression fraction, the more you increase that patient's chances of survival. And the more you disrupt that compression fraction, the more you disrupt that patient's chances of survival. And so if you are just kind of like haphazardly putting on that mechanical CPR, you're allowing responders in the room that don't have any experience with it to place it. And they're stopping compressions and they're sitting that patient upright, which is displacing their blood volume down to their pelvis. And you take 30 to 45 seconds to place it. Then you're not helping that patient. It's not doing anything for you. You might as well come in and sit on that patient's chest for 30 to 45 seconds for all the good that that's doing. So you need to have a process for placing it, a process that involves a very, very brief pause in compressions, a process that does not involve moving the patient at all. You never move a patient in cardiac arrest. You don't roll them, you don't sit them up. The only time you ever move a patient in cardiac arrest, outside of specific H&T situations, is to get them off of a bed or somewhere else where it's prohibitive of doing compressions, or if you're performing a vector change by putting pads on anterior, posterior because you have refractory VFVT, something like that. So if your mechanical CPR implementation is not perfected, you guys are not training on it, everyone doesn't understand how it's going to be done, then chances are you're probably lowering your patient's chances of survival. And if you're going to choose one over the other, choose the Lucas. What's the Zoll one? That thing is garbage. We have them here in rural area and have increase in ROSC. ROSC is not the thing. Survival is the thing. And not only that, but quite often what mechanical CPR has revealed to services that have seen sudden jumps in their ROSC and maybe survival when implementing them is that they were doing really crappy CPR. before that. So if significant bleeding, risk to life, can give O positive to pregnant patients. Yeah, you got to save the mother to save the baby. Lactated ringers is 50 cents cheaper for a 1,000 milliliter bag than normal saline. I don't know about that because I don't get into that stuff, but also Lac LR does not last as long as normal saline. Isn't that correct? That's because they will have to put in a chest tube as far as docs getting upset about performing needle decompression. Okay, well, if they needed needle decompression, then they needed a chest tube. So what are we upset about here? We all got to do the things that we need to do. As an ALS provider, what is something that basics generally do that you wish they would stop? I don't know, because, I mean, you know, when I'm working with a basic, they're certainly not doing anything that I didn't want them to do. I mean, we don't have two heads doing different things on the call. You know, the flow flows through me down to the basic. Now, if you're talking about maybe like if I was an ALS crew showing up to the scene of a BLS crew, empirical oxygen administration, you know, for everything, you know, is probably something they shouldn't be doing. There should be a reason to give oxygen. Trendelenburg positioning shouldn't be done. But overall, I'm not sure. If anyone else has some insight into that, I would love to read it. Decompression commits a patient to a thoracostomy tube as long as procedure indicated. Do what you need to. Exactly. This notion of, well, I don't want to do a needle decompression because they're going to get a chest tube. Well, that's what needs to happen after a needle decompression. And I'm skipping over some comments here that, you know, are just, you know, general contributions to discussions here so I can cover questions. If a fire truck can come equipped with a refrigerator, no reason an ambulance can't carry blood. I mean, listen, there are some logistical reasons why it may be very, very cost prohibitive for an ambulance to carry blood. But at the very least, we should have a mindset in EMS that this is where we want to get to. Mechanical CPR devices decrease pauses and compressions during transport. Fact. Fact. Transporting a patient with any sort of CPR, it doesn't matter if it's manual CPR or mechanical CPR, lowers the chance of survival. Fact. Get the hell out of here with that bullshit. When you transport a patient, you subject them to inertia and forces that their body cannot self-regulate. So you have constantly increasing and decreasing intrathoracic pressures, constantly increasing intracerebral pressures, and you simply cannot manage that in the back of a moving vehicle, and it lowers the chances of survival. Mechanical CPR is not an impetus to transport a patient. It's just not. The data is against you. Stop trying to outsmart the science on this. It is resulting in less people being alive today. You don't have a right to transport a patient in cardiac arrest. Soapbox. Actually, if you dart a chest and it's not a pneumo, they can just remove the cath. That's probably true. Our medical director doesn't want video laryngoscope. I think it will improve success rates. Thoughts? In the U.S., first pass success rates are terrible. If you look at the PART trial, which compared outcomes in cardiac arrest between supraglottic airways and endotracheal tubes, the survival rates were higher with LMAs, supraglottic airways, and the first pass success rates in the U.S. were 51%. Why would you not want to improve that with video laryngoscope? And it's also kind of a ridiculous position because you look around you and everyone is moving to video laryngoscope because it provides you a better way to visualize the chords and improve your first pass success rates. The notion that you're going to be this island unto yourself and say, well, we're not going to do this is ridiculous. Now, if your service has like 80% first pass success rates without it, I guess don't change a thing, I guess. But that is a strange position to take. The point is it decreases those pauses once it's in place. We love decreasing those pauses, okay? But we don't like moving a patient who's in cardiac arrest. Like I said, mechanical CPR is a utility that if you use it properly can benefit you from a utility standpoint. It frees up manpower. It does, in some circumstances, reduce pauses. But it is only a utility to allow other people to do things that they can be doing. It's a cognitive offload in some instances. But outside of that, it provides absolutely no impetus to do anything else but just keep providing a quality on-scene resuscitation. Someone who's about to start medic school, would you recommend reading questions and answers? No, I would recommend reading your textbook over and over and over again and memorizing your medications. That is the biggest benefit you're going to provide yourself right now, is getting ahead of your reading and getting that cognitive offload of memorizing your medications. Well, I mean, I didn't see that you had a second part to that. Would you recommend reading questions and answers or audiobooks to study? Reading engages your critical thinking a lot more than listening does, but that doesn't mean that you can't do both. I mean, listen to audio stuff when you're in an opportunity or an environment where you can't read, like driving. But if you have an opportunity to read, reading question and answers engages your critical thinking more. Hello, Texas. Good to see you. Yes, the Autopulse is trash. Although Rialto Fire uses the Autopulse, and they have, according to the data they published, some pretty significant survival rates. But I think I don't want to criticize Rialto Fire or overly scrutinize them, because I don't want to be guilty of people that, like, information is delivered to them, they do a 5-second analysis and then start trashing stuff. It takes a long time to do a critical analysis of data. So Rialto Fire is producing incredible results. It doesn't mean it's because of everything that they're doing. Like they position a patient at a 30-degree angle, they use the Autopulse, they use the rescue pod and all this sort of stuff. That doesn't mean that all of that stuff is contributing to survival. It just may mean because they rededicated themselves to a quality on-scene resuscitation, and that other stuff is contributing, is a non-factor in all of that. But they are producing results. I'd be curious to see if they started peeling away some of this stuff, like the heads-up CPR and the rescue pods and all of that. I'd be curious to see if they peeled away all those other things and just committed themselves to high-performance CPR, if the results wouldn't be similar. Enjoying your live, but gotta run. Thanks, Doc. I appreciate you, man. I appreciate you clarifying some of that stuff. Morning, Mike. Got to see a few minutes of your live last night before I got a call. Love your live. Thanks for doing it. I appreciate it. And unfortunately, all these people are saying this stuff, and these comments have been hanging out in the air for a few minutes, so I'm sorry. New Orleans EMS carries and uses blood. Yeah, see? It can be done. A local facility has Trendelenburg as SOP. I approached the medical director and I'm a doctor. God. That is the worst way to recruit someone to your line of thinking, is to invoke your certification. You know, and nothing angers me more than I'm a doctor, or I'm the medic and you're an EMT. If you can't defend your position, all you're doing is proclaiming to people that you're an asshole, and they're actually less likely to get on board with what you want. Trendelenburg position may provide a very, very brief displacement of blood back to the core, but it is very, very transient, and the body just overcomes that eventually, and even it levels itself back out. And in some cases, you can actually harm the patient by doing that, by causing the heart to work much harder. Do you work codes in the rain? I've never had a code in the rain. But like I said earlier, there are times where you have to move the patient, and um, we certainly don't want responders out there in pouring rain. So if you can very quickly and efficiently get them to a dry place, that's probably something you'd want to do. We don't want to defibrillate patients in pouring rain. We don't want $21,000 pieces of equipment sitting there and getting soaking wet. Not that that matters over, having a quality resuscitation, but there's environmental factors that affect whether or not you can work a patient right there for sure. The only time I transported a CPR patient was a severe trauma that I had zero way of treating in the field. You do have a way of treating those patients in the field. In fact, there's specific interventions that you should definitely be treating in the field, including bilateral knee decompression or finger thoracostomy. If you're allowed to do pericardiocentesis, getting a advanced airway or a surgical airway or whatever it is, but all those things should be done right there and then, and before you consider CPR. You shouldn't be leading off with CPR and traumatic arrest because you just make things worse. CPR is an intervention for medical arrest, not traumatic arrest. Sometimes you have to transport codes. That's inarguable. Well, of course you do. Of course there's some codes you have to transport. But we can't like negotiate ourselves out of an empiric approach to cardiac arrest by talking about exceptions. So generally speaking, in the discussions that we have about cardiac arrest are in the 80%. And what I mean by that is that 80% of out-of-hospital cardiac arrests are from suspected cardiac origin with no other confounding factors. And so that's what we're talking about. The other 20% still are comprised of a significant amount of people that don't need to be transported, but some do. So there are such things, there are like what we call, political transports, meaning we're getting them off scene because there are just, the reasons are so overwhelming that we need to move them, that we just have to move them. And it's the sort of thing that you can't codify it or quantify it on scene. You just have to move. Such as your safety. There are certain communities that are not educated on the benefit of working a patient on scene, and people are becoming very, very upset and agitated, and you just have to move. There are patients that fall within the H's and T's that need an intervention that we can't provide. They need to get moved. There are several instances where a patient needs to be transported, such as you have a system where they can go to the cath lab with the Lucas going, where they have ECMO. But the specific conditions need to be met in those situations, such as refractory VF and VT. And just remember, what population benefits the most from being worked on scene is pediatrics. Good morning. Just got off a 24, put in my first eye gel. I hope that really went well for you, and I hope that, you got some muscle memory in there. I'm all for an eye gel over an EPA to increase consistency. Over an OPA to increase consistency. Well, it's not eye gel over OPA. I mean, one of them is just allowing you, to have an open airway to perform mechanical ventilations with a mask, and the other is allowing you to get oxygen more directly to the lungs. I certainly encourage people, if you are arriving on a cardiac arrest and you're within the first couple minutes of the arrest, not meaning that, it's been literally minutes since they were alive and now they're in arrest. I would certainly encourage services to consider just dropping an OPA and working that patient with passive oxygenation for the first few minutes prior to getting an advanced airway and increasing the intrathoracic pressure. What do you think is more traumatic on a patient, physical restraint or chemical sedation? Physical restraint, without a doubt. We underutilized chemical restraints. If you want to transport a patient safely and they need to be in physical restraints, there's one thing to putting those physical restraints on to essentially provide a physical mental kind of like reminder that they can't move, and just to prevent them from grabbing things or hurting you or hurting them. That's fine. That's where physical restraints are helpful. But if you have a patient that's just having a massive catecholamine dump, and they are doing everything in their power to resist, and they're pulling at those restraints, and the veins are bulging out of their head, and they're literally sliding down and like choking themselves in the seat belts, and they're screaming and raging, that's not good for them. That is a terrible, terrible thing for them, and it is a kind thing to do. It's compassionate care to provide chemical sedation at that point. And the notion that we would restrict a patient's movement till they have absolutely no freedom of movement, to me, that is not quality patient care. And we need to stop being afraid of chemical sedation in those specific situations, because it's just terrible for a patient to be transported under those circumstances. I read that rescue pod doesn't have much effect in cardiac arrest. Not on its own, but it's supposed to be used in a bundle of care. So the way that Zoll would want you to use it would be you would be using the rescue pump, which is that suction cup that you use to not only push down on the chest, but to pull up on the chest. They're supposed to be used in conjunction with each other. But so far, the body of evidence doesn't support even the rescue pump and the rescue pod being used together. Pulling rank on someone will only make them trust you less. Absolutely. Why are docs disagreeing with performing CPR in the field for 40 and then transporting patients to the hospital? Most doctors are not. If a doctor is saying that, then he or she, God, I hate when I do that. I really hate when I refer to doctors as he and nurses as she. Growing up in a patriarchal society just infects you like that. That is such a terrible thing to do to, a professions that are getting increasingly diverse. But most physicians are outliers that say that. You talk to almost any physician in an ER and they're going to tell you to work them on scene. Headed out, thank you so much for all your time on this app. I appreciate it. Good morning from Texas. Good morning to you. Wet environment plus electricity equals more patients. Yes. The character limit really holds me back from giving pertinent details to you about my transport. You can send me a message on Instagram, EMS Avenger on Instagram. My last code, if we stayed, I'm sure the husband would have killed us. I can deal with one person getting upset, because that person, when he does an inquiry into that after the fact, if he speaks to a lawyer or whatever, they're going to be presented with the right information, and that one person isn't going to hurt you, and you have to do what's best for that patient's loved one when they're not trying to do what's best for their loved one. But a crowd is different. That crowd can actually move in and hurt you. There's some sort of crosstalk here that I'm not going to go back and try to catch up on. I'm sorry. Carrying blood is a good goal for EMS, but proper training is important before this should be done. That goes without saying with any intervention. And I often see where there isn't that proper training. I remember when Zofran was introduced to most EMS services. How many services actually was provided proper education on that medication? Not a lot. They just gave it to you and said, here, give this instead of Phenergan. And I would go around and ask people, hey, do you know how this works? Well, it's an antihistamine, isn't it? There just wasn't any education on that medication. Now imagine giving somebody blood and not giving them that education. But for the most part, you are not going to have a service implement administration of whole blood without proper training. I had an ED nurse practitioner try to tell me codes just need to get to the ED because we have more resources. That is horse shit. And they need to be educated. And what you need to do in those situations is actually write to your medical director and let them know the name of that nurse practitioner so there can be a conversation and some education. Where do you find your literature for advancing your knowledge? I like studying. You know what the biggest game changer for me was? Getting on what's called MedTwitter. MedTwitter is a hashtag on Twitter where it essentially indicates that you're discussing medicine. And then also the hashtag FOAM, which is FOAM, free online, excuse me, man, excuse me, free online, free open access medical education. It's basically people who are providing education without gatekeeping it through paywalls. And I just found that there were so many influencers and creators and researchers and physicians who were just out there sharing information and sharing studies. And so I just started following all these people and learning who the reputable people were. And before you knew it, my Twitter feed was just a daily education. And then I started making contacts with some of these people, following them on different forms of social media. Started following specific journals on social media, and before you knew it, my social media just became a thing to where I logged in. If there was a new study, it was going to be right there on my social media. And not only that, but I just have a very curious mind. So anything I didn't understand, I would just go down the Google rabbit hole and just teach myself. What is your ideal ratio? We usually have 4 ALS and 4 BLS providers on a cardiac arrest. You know, I wanted to do a video on this the other day, but I couldn't find the study online. I thought I had saved it, but I couldn't find it. But a study was published not too long ago that said, I think that the optimal amount of people on scene that was associated with increased survival was 7. And it made no distinction with ALS and BLS, but just having that many people to be able to rotate compressors, to be able to manage the airway, to have one person at the monitor, to have a scribe, to have one person managing family, that was the optimal amount of people that contributed to survival and cardiac arrest. Magic number is 5. That's actually 7. Now, I think 5 would be when we achieve this number, we can do everything that we want to do, but the data says that a couple people more than that is actually associated with more survival. And I'm not really disagreeing with you. I mean, 5 people is a great amount of people to have on scene. You can basically do everything that you need to do with 5 people. Most fire departments operate with a minimum of 6-man teams. I believe it's been a while. 6 people is great. You know, having that many people on scene is fantastic. In a cardiac arrest, I really appreciate having that manpower. It allows me to stay bird's eye view and run the call and keep an eye on everything. And the one thing that I want to keep an eye on the most, and everyone that is in a position, you know, to have influence on a cardiac arrest should be implementing this practice, which is one person needs to be constantly watching the compressor, because that person's going to get tired and they're going to start leaning on the patient. There are some people that inexplicably start drifting over to the left side of the chest as if they think that being directly over the heart to where it kind of sits a little bit to the left is better, and you need to get them back over to just above the xiphoid process. But they also start to slow down, or maybe they're going too fast. But there needs to be someone who is watching the compressor and correcting them when they start getting tired and ensuring that a non-tired person is taking over for them. Yeah, that's one of the situations where more is better is cardiac arrest. I think my questions actually accidentally got bumped when I switched screens. Yeah, I missed a few there. Also, there was some crosstalk there between some people that I skipped through, so I may have missed something. They had me run a mock code for nursing school. My professor and classmates were wide-eyed at me. Yeah, you get a medic in nursing school and you're going to run circles around them in that regard. Day off today, brother? Yes. I just did 4 days in a row, 3 14s and a 12. And today is what I call my 0 day, which is I don't do anything today. Nothing. I will not do anything productive today whatsoever, except drink some coffee and later eat some wings that I will put on my grill. How do you... Oh, I think I remember somebody asking that earlier. How do you feel about iStats on EMS trucks? I mean, I would love iStats on EMS trucks. And if they can make them a lot more affordable, that would be great. I mean, to have all that data right there, that would be fantastic. But, you know, there needs to be increased education as well to go with those iStats, you know, because a lot of medics only get that information from critical care classes. Different size masks make a difference in BVM ventilations. Everyone is not a medium. That's true. Absolutely true. You know what I'm waiting for? I'm waiting somebody to fix the mask issue with BVMs. It has been far too long with this horseshit of people doing the CE method, which is a terrible way of holding the mask on a patient, you know, and providers that simply will not have one person hold a mask seal while the other person ventilates. And that's another benefit you get with 7 people working on scene of cardiac arrest, is during mask ventilations, you can have someone hold that mask seal while the other one ventilates. But I'm waiting for that mask that has this little plastic lip under the mask that seals in between the lips and the teeth, so that when you put pressure there, you form a perfect mask seal just by pushing down on the mask. I'm waiting for that mask. The idea of running a Chem 8 and CVC in the field, knowing when you need blood, platelets, chemicals, yeah, I would love to do a Chem 8 in the field. I want to know all of those things. You know, quite often I've seen on a 12 lead or on the rhythm where we'll have like a transient right bundle branch block, and they have these, you know, hyperacute T waves and you know, prolonged QT intervals, and I suspect hyperkalemia, but I would love to be able to see that on a Chem 8. Because the iStat data would definitely increase patient outcome. Well, I don't know about that. I don't know about that. Because sometimes you just knowing it just means that you know it. The education has to be increased with the iStat. Otherwise, it doesn't provide much of a benefit. Other than maybe getting some resources going in the ED. At that point, with a mask like that, wouldn't a supraglottic airway be safer? Well, just remember that not all mechanical ventilations are performed on people who are unresponsive. I've had plenty of situations where I needed to perform mechanical ventilations or assisted ventilations on someone, you know, who wasn't a candidate for CPAP or something like that. But a supraglottic airway isn't necessarily something you want to go right to in some situations. You just want to get that mask on and start providing ventilations. And having a mask that has this little lip there that you can kind of screw into between the lips and the teeth just allows you to immediately get a better mask seal right off the bat. Hopefully iGels would be a game changer so providers don't have to worry about mask seal. I mean, there will never be a situation where we're going to show up on scene and not necessarily start with that mask. Well, I don't want to say never, but it's certainly not going to happen anytime soon, and having a better mask is just going to benefit everyone. How do you check for fake teeth before intubation? I've never been taught. I just pull. I mean, you can pretty much tell when somebody's wearing fake teeth. I mean, you just pull up the lip and you're like, you know, that doesn't look real. But I'm only really concerned about fake teeth if they're like actually inside the oral cavity. You know, if they've got dentures in and they're stuck pretty well, I don't care. I'm not going to try to remove them. I mean, you shouldn't be putting any pressure on the teeth with your laryngoscope. So it should only be an issue if those dentures have come loose. And in that case, you're going to see them the minute you put that scope in there. The big problem with POC testing is the lab requirements. How accurate is end tidal with an air cue or LMA? Pretty accurate. I mean, if you have a good seal, you should be directly over the larynx, especially with the eye gel, and so it's fairly accurate. And just remember, you're definitely covering the airway with those supraglottic airways. Your ventilation in may not be completely optimized with whatever your supraglottic airway is, but almost all of your exhalation is going to get funneled through that airway because it's the path of least resistance. So, I mean, down to the last digit, maybe not as accurate, but guiding whatever you're doing one way or the other, it's going to be accurate enough. In our facility, if we get questionable criticals from a main lab, we double check. Well, certainly, and it's just like if you get a blood pressure and you get something that surprises you, you double check, of course. Man, the more you talk, the more I want in-depth conversations with you. I get that all the time, and especially from people who live in my area. They're like, hey, do you want to get together and have coffee and stuff like that? My answer is always yes, but I always tell people that it's very easy for me to maintain this for an hour, on TikTok, but an in-person conversation may be completely different. iGel should be an EMT skill. It is in many, many areas. It is here. Anybody can drop an iGel in my area. And yes, I absolutely agree. I would think that more areas than not have made iGels an EMT skill. Thanks for sharing your knowledge. Thank you for being willing to be present and to talk about it. I consider myself to be somebody who is talking about medicine with other people, and also someone who is open to receiving a course correction. I'm actually going to, not within the next couple of days, but within the next couple of weeks, talking about my evolving mindset on dextrose and cardiac arrest and fluid and cardiac arrest. You know, I've shared a lot of the data that's out there that's against the administration of dextrose and cardiac arrest, and where there's a lack of supporting evidence for the administration of fluid empirically in cardiac arrest. But I'm taking a beat on there and analyzing my position because I think that there may be some room there to look at that a different way. So you'll probably see a little bit of a pivot from me in the coming weeks on both of those things. ER techs can drop an iGel here. That's great. I think that should be a thing. Ah, man, I love my coffee. I love my coffee. Activity is starting to trickle down here a little bit. What time is it? It's 11:38. You know, as long as we're getting good action, getting good interactions here, I'll stick around. I think we'll put 11:45 as a soft cutoff. We'll see what happens here. I've watched ED docs fail tubes on difficult airways and grab the iGel they just removed. Yeah. I don't. This mindset of removing a functioning iGel makes no sense to me. I understand that at some point or another, you know, a definitive airway is going to have to get put in place, but there's no reason to rush that. Absolutely no reason whatsoever. Recommended reading material or questions and answers for someone who's in medic school. I didn't use anything supplemental when I was in medic school. The most beneficial thing that I found was to have conversations with people, you know, who were in the know. and to really just break down pathophysiology. But the best thing that you can do for yourself in medic school is to read your actual course content over and over and over. If you can get 3 reads of your material before you test, and you can memorize your medications, like you can just nail down your medications, you are going to be on the fast track to doing well in medic school. You know, a lot of people want to find extra stuff to do, but success really comes down to doing your basics, which is your reading, your pharmacology memorization, and managing your time well. Time management is one of the biggest factors affecting people who are in medic school. You know, they don't do the reading, they don't do the work, they don't do the studying, and they say, I just can't find the time. But I think that if you were to bring a third party in and break down your time management, you know, and looked at like, this is how much time you spent watching Netflix, this is how much time you spent doom scrolling on Instagram or whatever your preferred social media is, this is the amount of time, you know, that you spent going out with friends, this is the amount of time you spent drinking, and this is the amount of time that you spent studying, we would all be forced to admit that the time is really there to do the work, and we're just not using that time effectively. Can you please explain why coronary artery disease can lead to atrial fibrillation? Thank you. Well, it's not really the number one reason why people go into atrial fibrillation. It usually has to do with pulmonary issues and issues of not calcification, but of fibrosis around the area of the pulmonary artery. That's generally speaking what starts the issue with atrial fibrillation, is because the SA node is located so close to the pulmonary artery. So people that have pulmonary issues like COPD, chronic hypertension and that sort of stuff, it leads to increased pressures in the pulmonary artery, which starts to make that area of where the pulmonary artery originates a little bit tougher. And so that starts to affect the SA node because the tissue experiences less automaticity. And so you start having all that multiple ectopic foci around the SA node instead of at the SA node. That's the biggest contributor to atrial fibrillation when it's not related to a heart valve. Now, coronary artery disease can lead to atrial fibrillation because you have poorer perfusion to the SA node. And anytime the SA node doesn't get perfused well, you're subject to tachydysrhythmias like atrial fibrillation. But coronary artery disease is not the primary reason why you see people in atrial fibrillation. He had more than 150 characters to explain, and I didn't. Yeah. You know what I realized I needed to do today? You know, when you do a live, it ends up setting, you're very welcome, it ends up saving a recording of your live. TikTok does. And I never go back and look at it, but I realized that I could probably go back and trim some of this stuff out. And put it out as a video talking about specific pathologies and things like that, like the AFib right there. So on the subject of atrial fibrillation, how many people have been taught that if in the field, if you're going to convert atrial fibrillation, because for whatever reason, they're unstable, massive chest pain, whatever, if you're going to convert AFib, that you need to ensure that they not only have a prescription for anticoagulants, but that they're compliant with their anticoagulants. How many people have had that drilled into them? I'm curious. A lot of people post it to YouTube. Oh! That's what I'm going to do. I'm going to start posting my lives to YouTube. That's a fantastic idea. I have a YouTube channel. I haven't known what to do with it. And that is a fantastic idea. You are a genius. So you have not been taught that. You were taught that. Cardizem. Well, yeah, I mean, that's what we would use in the field. Or, cardioversion. But either way, converting atrial fibrillation is a problem if someone is not taking anticoagulants. So here's the pathology that happens. So you have these multiple ectopic foci outside of the SA node. All these little myocytes that are really, really upset that they're not getting electricity passed through them. And so they all want to be in charge, and they all start generating their own electricity because all myocytes are capable of automaticity. And so there's 1,000 different little foci that are all trying to get the heart started. Now, they all can't get through the AV node because the AV node is a calcium channel as opposed to the sodium channels that exist in the atria. And so all those impulses hit the AV node and they all slow down. Now, a lot of impulses can still get through, somewhere between 150 and 200. 200 that's really getting up there as far as the impulses that can get through the AV node. So what that means is that because there's not one guided impulse through the atria, there's like 300 of them, the atria just starts quivering, right? Well, you have these two flaps that come off the atria. Each atria has this flap. It's called the auricle. It's like this little dog ear, and we don't talk about that a lot in emergency medicine. But when the heart is just doing its thing, it's not under any stress, you're not exercising, you yourself are not stressed, you don't have a disease process that's causing any overfilling in the atria, not much happens with those flaps. They stay collapsed against the atria. But in times of overfilling, you're exercising, you have hypertension, something that causes overfilling of the atria. You may just have a lot of fluid on board because you just, drank a massive, like you just drank a liter of fluid within a minute. Those flaps, the auricles, suddenly start inflating and they handle the overfilling. And in that normal physiology, the auricles do contract and push blood back out into the atria before the atria snaps it down into the ventricles. In atrial fibrillation, none of that natural physiology is happening. And so that blood, during that quivering process, can spill into the auricles because it's not getting collapsed into the ventricles. And so you start getting blood collecting in those auricles and it's not getting ejected from the auricles. And so it starts coagulating in the auricles. And then you suddenly convert atrial fibrillation with either cardizem, some sort of calcium channel blocker, or through cardioversion, and suddenly you have increased atrial pressures, and so the atria is trying to get that blood passed through again. And because there is pressure in the auricles, because there is coagulated blood in there, the auricles contract to get whatever's in there out. And so they squeeze those clots out into the atria, which is then passed through into the ventricles and through the rest of the body. And that's where you get your strokes and heart attacks. So that's why it's very, very important to know whether or not only your patient has a prescription for anticoagulants, but they've taken it within the last 24 to 48 hours. I carry cardizem, but our protocol is for narrow complex tachycardia that adenosine doesn't convert. Yeah, I like cardizem as a first-line agent for a reentry rhythm like SVT because it doesn't give that patient that sense of impending doom. Protocol says just to monitor stable AFib, which should be the case. We shouldn't be converting AFib just for reasons. But also, if your patient is shitting the bed, if we don't convert them, they may die. And so we would rather them have a clot than be dead. You really just have to critically analyze each specific call and ask yourself, what's going to harm the patient first, death or the clot? We carry heparin in our protocol states to give that prior to cardizem for symptomatic AFib. I love that protocol. Thoughts on working the problem on scene versus a Lucas. Those are not mutually exclusive. It's not work the patient on scene or put the Lucas on them and transport. It's work them on scene, period. That's how you work a patient on scene. When you transport a patient, you significantly lower the chance of survival, and the Lucas does not improve that. I just went on a huge rant on this about 30 minutes ago. The Lucas is a tool. It's a utility that helps you accomplish compressions without tiring responders. That is the only benefit to Lucas. You don't transport a patient because you have mechanical CPR. Survival rates do not improve under that mindset. Stop using mechanical CPR as an excuse to transport patients. It does not improve survival. What about putting a second set of pads on in refractory VFib and shock anterior posterior? I'm smiling because this is something we're talking about a lot right now, because there was just a study that was released called the DOSE VF trial that talked about dual sequential defibrillation. Dual sequential defibrillation is when you have two cardiac monitors, and this is for refractory VFib or VF. And so you have two cardiac monitors, and you have anterior placement and anterior posterior placement, and you defibrillate like this. Boom, boom. I don't snap very well with my left hand, but you just boom, boom. And we are seeing increased survival with that method. The caveat is that we're also seeing increased survival with vector changes. So you should always start with anterior placement, because there's no data to suggest that there is any sort of measurable improvement with anterior posterior, despite what Zoll would say. Never trust a study from the manufacturer. But if we're not seeing results with defibrillating that patient with anterior placement, then we should be working on what's called vector change. And the first thing that you should look at with vector change is making sure that your vector, which is, consider it to be a line, your defibrillation vector, you have a pad here and you have a pad here. If I draw a line in between my two hands, that's crossing the heart. But sometimes there's some lazy placement. Maybe this pad is just a little bit lower and this pad is right here. Now if I draw a line, I'm actually going underneath the heart, and that's a poor defibrillation vector because you're not putting electricity over a lot of cardiac myocytes. And so we want to move those pads to the optimum placement and then defibrillate. And if that doesn't work, we want to switch to anterior posterior. And if that doesn't work, then we may want to consider dual sequential defibrillation. But I love your line of thinking, because that's what we should be doing. But we should be paying attention to that vector right off the bat. You should be looking at those pads, and in your mind, you should see that line that goes right across the most muscliest part of the left ventricle. So yeah, love the vector change. Thanks for the answer. Unfortunately, my protocol transports. How can I promote the change? You have to invite the people who are decision makers to be a part of the discussions. And when you become, and be yourself, a public part of the discussion, post on your social media to all the data that's out there about working on scene. And here's the thing, the people that are arguing against it, they know that survival is higher when you work patients on scene. And there may be other factors involved, and I'm not saying it's malicious, but there are other factors involved with them wanting to transport patients. Sometimes a matter of billing. Sometimes it's just a matter of fear that they're going to see lower survival rates. But you can't be in medicine at this point, or at least you can't be in medicine and be someone who has to make decisions based on data. You cannot be in that position without knowing that survival rates are higher when you work a patient on scene. But just be a public part of the discussion. And the more public you make that discussion, and the more you bring that patient to the public, those are the people you have to convince, the public, the taxpayers, the people that are in the service area of your transport agency. Win them over. And then your agencies will have no choice but to start changing their practices. You're basically doing an end run around your agency. I think we're going to do about 5 more minutes here. And then I got to go off and do nothing. Really, I'm just finishing my coffee and I'm getting hungry now. So this has been a good live now. And I'm so stoked about the person who suggested I should put my lives on YouTube. I've wanted to do something with that YouTube channel just, to make it useful. And I think that is such a great idea. That is such a great idea, just to put the lives on there. If for nothing else, just to have the content on there. Gonna head out. Today is day 1 of 5 days off, and I've got tasks here at the homestead. Have a good day, man, and be safe. Always glad to have you around, man. Thanks, Mike. I appreciate it. As always, much love, and I always enjoy our lives. Yeah, I really like the lives. I like the exchanges that happen here. And you know what I really like? I like that it's not salty in any way. There was somebody earlier, I think they signed off, but there's somebody earlier that was kind of arguing for transporting a patient with the Lucas on, and I basically bit their head off, and they just accepted it, and we just rolled with it. That is just fantastic. It was just fantastic. There was no ego there. I just love that. Stay safe and enjoy the day off. I'm definitely going to do it. Definitely going to do it. Our best ROSC rates from last year were both bystander CPR. Yeah, that's the most important part of the chain survival, is in that 10-minute period between when somebody arrests and when responders get there. We all look at Seattle as being like the benchmark as far as survival goes with, EMS resuscitation strategies. Now there's some nuance to this, but every other person with a VFib arrest in Seattle is going to walk out of a hospital. Like I said, there's a lot of nuance to that, and they play fast and loose with their data on that. But there's no arguing that they have some of the best resuscitation rates in the nation. But is it because of the Medic One program? No, it's because everyone in Seattle, in that area, they have to be taught CPR in high school, and you cannot swing a dead cat in Seattle without hitting an AED. That's why those survival rates are so high there. I just got my first ROSC patient the other day as a medic. That's awesome. Did you follow up and find out about survival? Survival, 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 survival. That's what we want. Thanks. Oh, no, you are still here, Apple user. That's what I was talking about earlier. Thanks for your time. I thoroughly enjoy your videos. Thanks. I appreciate you, man. And I appreciate you just being, on the receiving end of my hurricane rant against the Lucas, or against the Lucas being a panacea, for cardiac arrest. What would be your number 1 intubation tool choice? The King Vision. I love the King Vision. I love just dipping that blade, barely dipping it inside there and seeing those cords and just slipping that tube in there. So beautiful, so beautiful. I'm the lead on my small town. Oh, but congratulations on that, ROSC, though. I don't mean to diminish the feeling there, because obviously we don't know about survival in most cases until we get ROSC. So, yeah, I mean, getting that pulse back and bringing that patient to the hospital with a pulse, the best feeling in the world. It's the best feeling in the world, and nothing can replace that. And, we all get in there to experience that. So, yeah. I'm the lead of my small town ambulance service, and I have had so many businesses want CPR training lately. Yeah, I mean, the Damar Hamlin thing did wonders for people wanting to know CPR. And we have, and you know what's wild is just the grounding that has happened in EMS since the Damar Hamlin case, showing us that we have a lot of work to do. And I'm talking about the 2 medics in Illinois who suffocated their patient by restraining them prone. But even then, we've had an example yesterday that, even we can do everything that we can in an out-of-hospital cardiac arrest, and sometimes it's just not enough. And I'm talking about Lisa Marie Presley, who went into cardiac, that's the daughter of Elvis, who went into cardiac arrest yesterday. And they did get ROSC on scene, but, I don't know if she rearrested in the hospital or if they just let her go. But, we need to be realistic when we talk to the public that is the most likely outcome in an out-of-hospital cardiac arrest, that that's just going to be the end of it for them. And it's very, very unfortunate. Would you recommend 12-lead ECG, the art of interpretation, or Dubin's rapid EKG interpretation? No. And here's the reason why. Number one, a lot of that actually isn't accurate. Number two, he's a pedophile and he is in prison. So please do not buy that book. Don't even steal it. Don't do anything. If you see a copy of it, burn it. She rearrested multiple times in the ED, from what I understand. Yeah, those people. So when somebody keeps rearresting like that, one of two things is happening. Number one, that person just really, really, really wants to die. There is a pathology there that is just like, I have had enough, and nothing that you can do can change my mind. Or you just keep getting epipulses, and the two usually are related to each other. But the constant ROSC is usually just an epipulse. That's all that is. Now I want to know, what book would you recommend? I have not gotten any of my knowledge from books. The most beneficial thing to me has been following people who are ECG experts on social media, because you get to see videos, you get to see discussions, and you get insights into rhythms and that sort of thing. And that's how I learn the best. So YouTube videos and ECG groups from social media are fantastic ways to pick up bite-sized bits of information over a period of time that can help you with your ECG knowledge and ability to do ECG interpretations. I fully believe that she didn't want to leave her father. We can get into the metaphysical here, sure. Were you around when we used to do high-dose epi? What are you referring to? Because right now, what we consider to be high-dose epi is 1 milligram of epinephrine. Oh, are you talking about when they would do it weight-based? No, I wasn't here when we did it weight-based, but survival rates were definitely lower when we did weight-based, and people would end up getting milligrams and milligrams and milligrams of epi in a cardiac arrest. What about learning a baseline for medic students? My textbook for the course isn't exactly the best. Yeah, unfortunately, EKG interpretation is generally learned in the field. You can learn to recognize a textbook perfect rhythm in school, but most of the time what we see is not textbook. There's a lot of nuance to it. And the best way to learn EKGs is to just do 12 leads on as many people as possible, and then take those 12 leads and show them to people who know about it. And because here's the biggest problem with EKGs is that, like I just mentioned, in school you get textbook perfect EKGs, textbook perfect third degree blocks, textbook perfect atrial fibrillation, textbook perfect atrial flutter. And a lot of the times, the 12 leads you get in the field are not textbook. And not only that, but even though there may be an abnormality to the EKG, it's benign and has, really no impact on their day-to-day function. So the more that you can get familiar with what we call normal variance, which is an abnormal EKG that just happens to be what's normal for them, like a right bundle branch block, or the presence of U waves or whatever. The more you see this abnormality, the easier it is to filter through this on a patient where it really matters. There's a lot of people who aren't familiar with the way that a right bundle branch presents when you look at the inferior leads. It looks like there's reciprocal changes there. And that's just actually normal. It's a normal presentation for a right bundle branch block. And sometimes a right bundle branch block in the anterior and lateral leads, in the septal and anterior leads, can look like ST elevation, and it takes repeated exposure to it to see that it's not ST elevation. And you have to constantly get exposed to that so you can start to filter out things that may be pathological but not harmful. You need constant exposure. Doing 12 lead as much as possible and then posting those 12 leads on social media or asking experts is the best way to improve your familiarity. Yeah, at one point we gave 5 milligram boluses. You got a pulse back, but that pulse wasn't worth anything. I told the doc I could bring a board back to life. That's right, you can get a pulse and a steak with that. I have finished my coffee, and the questions have slowed down. I've been live for 90 minutes, and it's time for me to just kind of take the rest of the day off. I probably will record some stuff, but overall I'm not going to do anything. This has been an awesome live, and I'm going to post it to YouTube, thanks to somebody's suggestion. Appreciate everyone who follows me, keeps up with me, and interacts with me. I really appreciate the interaction. Really, it's so rewarding. So I'm going to get going. Everyone be safe out there and have a great day.